Check. Hello.
A, B, C, D, E, F, the big one for response. We'll use those for response to the question. So you'll have a multiple choice question. The answers are A, B, C, D, E. You can press one of them. Then when you press it, you do not have to press the send button. All right? So that's what we will do. Okay, now the names are on. You can type the name, type your own name and press send. Everyone must do that. Because once we finish this, you cannot, now handset, on the back of your handset is a number. No, someone is doing it wrong. Okay, you need to enter it properly. Just enter your name. Is there some error here with the system? Just one second. I'll just start it once more. No, somehow it's got disconnected. There's some disconnection somewhere once. No. We need the ID. Just like Ashish has entered the name, everyone needs to enter the name. Okay, so Dr. Chaudhary is there, Ganesh is there. Handset number 32 needs to enter again. 63 needs to enter again. 35. You need to all enter your names. On the back of your handset, you have a number. Okay? So number 35, 20, 32, 70, you need to enter again. Just like the names they have entered, you need to enter it again. '18 also needs to enter again unless their name is true. Anyone needs help? If you need help, just raise your hand, we'll come and help you. Okay. Anyone else? Handset number 18. because once we close it, then you cannot, for the next 4 hours, you cannot participate. Anyone remaining? Yeah, just say, you need help?
Welcome everybody. We hope all of you must have done with lunch. Now we move on for next session. For that I would like to request Dr. Deepak Agrawal sir to welcome Dr. PK Jain sir with floral bouquet.
We'll just shake hands.
So, I request Dr. Ravi Rathod sir to introduce Dr. Jain sir.
You have to come from here because that connection is not nice.
Hello, good afternoon everybody. It's my privilege to introduce Dr. PK Jain. Sir is an eminent chest physician and intensivist and critical care physician, well known nationally and internationally, as well as he is consulted as a intensivist across the country for the difficult cases. He has been in the forefront in the establishment of critical care in India. He is passionate about teaching and training doctors and nurses internationally as well as at national level. He has graduated from St. Gias and KM Medical College, and he is a gold medalist during his post-graduation. He has done his MD, if I am not wrong, sorry, in chest. He has done his post-graduation in MD chest, and he is honorary chest physician and chief in ICU at Harkisandas Narotamdas Hospital, Mumbai, as well as at BSES MG Global Hospital, Andheri. He is a founder president of Indian Society of Critical Care Medicine. He is also chairman of Critical Care Education Foundation, chairman of Indian College of Critical Care Medicine. He is also chief examiner Indo-Australian Fellowship exam since 2004. He is also founder editor of Indian Journal of Critical Care Medicine. He is also editor in chief Critical Care Asia. He is also on editorial board of Intensive Critical Care. Then he is also on chest editorial board. Then he is also a well recognized teacher in critical care medicine. Sir has also delivered more than 400 invited lectures at regional, national and international level. Sir has published many chapters at national and international textbook, including API textbook of medicine and many national and international journals. And he is the only Indian to be invited as international teaching faculty at World Congress on Critical Care Medicine, Sydney, Australia in 2002. I welcome Dr. PC Jain sir to deliver his lecture on today's session. Thank you.
to write fluids, you will take 30 seconds at the most. Glucose, glucose saline, glucose, glucose saline, add MDI in one, add potassium in one. But there's a lot of science behind it, and we're going to do it interactively. We'll see your answers and then we'll discuss the right and wrong ones. Now, when you see a symbol like this, it means it's an audience response and you will need to participate. But you will participate only after the timer starts here. Okay? Now, this first example is a 37-year-old lady who presented with 4 days of severe diarrhea and poor oral intake. Her clinical condition is consistent with moderate hypovolemia. You have the electrolytes here, sodium 142, potassium 3.7 chloride. You have the blood gas here, and you have the urinary electrolyte. I want to ask you a simple question. This is not unusual, right? Patient comes with diarrhea. What would be the fluid that you will give in the first hour in this patient? Will it be, since this is the first one, I'll just read it out for you. Will it be normal saline with 10 cc soda bicarb? Will it be dextrose with soda bicarb with KCl? Will it be half saline with soda bicarb, half saline with KCl, or just normal saline? Okay, now I'm going to start. The timer has started, so you start voting. Alright? Switch it on. If the handset is not switched on, press the red button and start answering A, B, C, D. So 6 people have answered. We are seeing here, everyone should answer. 19 seconds left. Very simple day-to-day problem. Child's play for a physician. Okay, below threshold means that more than 50% of you are wrong. That's what the meaning of below threshold is. And let's see the graph. 12 of you did not respond. I think to enjoy this program, everyone must answer. What is the point? I don't know who is answering what. So in your anonymous state that you are in, you can press the best answer. 4 of you said A, 3 of you said something, 2 of you said something, 2 of you said D. And therefore, multiple answers. The correct answer is D, half saline with KCl. And we will see why this is so. So out of how many people are there in the group? Let's see. 7, 11, 20, 32. There are 32 people in the audience. Only 2 of you got it right. Alright? You will see what is why it is so. Let's take another example. I want more participation. A 42-year-old female with recent onset of generalized weakness and postural giddiness. There is no history of hypertension or diabetes. She denies vomiting, diarrhea, or use of diuretics. On examination, can all of you read this? Yes. Okay. So clinical condition, labs. My question is, why is she hypovolemic? Okay, I will give you time to read and then I will start the timer. The beauty is, you know whether you're right or wrong. And if you're wrong, why you're wrong. I'm starting the timer now. Okay? The timer is started, start voting. If your handset is off, press the red button to start it. No one has voted so far. One person. There should be 32 people here. Come on quickly, few seconds left. Lot of people to vote. At the most you will be wrong. What big deal? Everyone should vote. Alright. Now, majority of you said B, some of you said A, and 11 people still did not vote. The correct answer is C, laxative abuse. One of you got it right. Good for you. But you see the beauty of it is, you know the issue about learning medicine is, there is no one to tell you when you are going wrong. And it is a gift when someone can correct you. Because you make a mistake, patient dies, who is going to know? And this I think, that's why I started with something which looks very simple, but isn't it an issue? Why amongst such a distinguished audience, one person got it right? Why are everyone else wrong? And I also want to know, why are 11 people not answering? The best place to make a mistake from the patient. Maybe the last question. A 56-year-old female is admitted to the ICU in an unconscious state. Pulse 120, BP is 90 by 60, serum sodium is 172. What fluid will you treat her with at this stage? Audience response started now. I want all 32 to answer. That's why you got the audience response system. Everyone, make a mistake. It's all right, but at least attempt it. See, half people more to answer. Okay, very close. Come on, 5 more people, 4 more people. Everyone should answer. All right. Anyways, still better. Majority of you, 20, said C. The correct answer is A. All right. And C is drastically wrong, and we will see why. But it's nice. That's what we've come here for. The beautiful symposium and conference workshop is meant for teaching, so we will see where we're going wrong. First of all, a patient who's hypovolemic, has less fluid in the body, will present usually with oliguria. And oliguria to a nephrologist means less than 400 ml of urine per day. But in the intensive care unit, when you're dealing with a patient, you do not say, yesterday your house was on fire, yesterday you were hypovolemic. It's got to be now. Within an hour of patient being hypovolemic, you should pick up. And for that, you really have to modify your definition to mean insufficient urine. What is sufficient? Half ml per kg per hour. You have urine bags, police catheter. Hourly urine output is something which must be done in every ICU patient who is critically ill, and this is a good rule of the thumb. So if a 60 kg person produces 30 ml of urine, that's the borderline. If he produces 25 ml, I don't panic. But if 2 consecutive hours, the urine output is less than half ml per kg, I need to diagnose hypovolemia and give fluids. Not when the nurse says, sir, 8 hours he has not passed any urine. That is not good medicine. After surgery, it's 1 ml per kg per hour, so 60 ml per hour. And if you have got tissue injury like trauma or rhabdomyolysis, you want 200 ml per hour urine output to flush the kidney. What answers you must think of in your mind to these important questions? In a patient, is he hypovolemic? If he is hypovolemic, why is he hypovolemic? Are there overriding priorities before I can write a prescription? What fluids to give? Because you know there's glucose, glucosamide, vinegar lactate, blah, 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 isolite B, isolite M, everything. Any additive and at what rate? There's a science behind it, and let's try to see this. First of all, is the patient hypovolemic? It's not difficult to make that out if you look at the patient, because if someone is vomiting, has diarrhea, is on diuretics, obviously is hypovolemic. Alright? History is important. Physical examination really is very confusing. It does not help you in any way. There are lots of reasons why you could have tachycardia or hypotension, or you could be confused. So these are confusing. We will not go into that. And lab values do not tell you if a patient is hypovolemic, because you can have low sodium or high sodium with hypovolemia. You can have low potassium or high potassium with hypovolemia. So this is not important. What is extremely important is urinary sodium. Today, the most sensitive method of diagnosing hypovolemia in a patient is to do a spot urinary sodium. And a urinary sodium less than 25 is hypovolemia. The problem, the importance of this is that if I have a patient who comes to me with a gastroenteritis and his heart rate is 150 and is passing 10 ml of urine per hour, obviously is hypovolemic. I give him fluids. So suppose I start him with normal saline. His heart rate from 150 comes to 100 and urine output now becomes 30-40 ml per hour. I will probably discharge him saying, I have done my job. The reality is far from correct at this point. We have certainly made him better, but there is no way of knowing that whether his heart rate should have, actually we should have given more fluids till his heart rate came down to 70. You understand? We have no way of knowing that. The only way you can do that is, thank you. Am I audible now? Yeah. The only way to know this is if you had done a spot sodium, urine sodium, when his heart rate was 150, you may have got it as 5. So you know he's hypovolemic. You give him fluid, you treat him the way you want to treat him, and when the heart rate is 100 and you feel he's good, again do a urinary spot sodium. And you may find it is 15 now, which means it is less than 25, he's still hypovolemic. Continue to treat him till urinary sodium becomes more than 25. And this is undoubtedly a very, very, very important thing which is done every day. But it's also important to know that there are few conditions in which the patient can be hypovolemic, but the urinary sodium is more than 40. And this is renal failure. Because the purpose of the kidney was to conserve sodium, it's failed, kidney failure, renal failure, and therefore your urinary sodium will be high. Patients who are on diuretics, just the sheer rapidity of flow doesn't allow for the gas exchange to occur. One second. Okay, and in metabolic alkalosis. Metabolic alkalosis, you cannot rely on urinary sodium. The reason is, will be explained later on if you get time, but when you have metabolic alkalosis, there's extremely large amount of bicarbonate in the body. Is this disturbing? Sound no? Is this better? Yeah. So, there's a lot of bicarbonate in the body, and the body, what will it do? It will throw the bicarbonate in the urine. If it goes in the urine, the bicarbonate takes sodium along with it as sodium bicarbonate, and therefore your urinary sodium becomes high despite your having contraction metabolic alkalosis or hypovolemic metabolic alkalosis. Fractional excretion of sodium, etc., are pretty useless. Now, it's not important anymore in modern medicine to know whether your patient is hypovolemic or not. What is more important and appropriate is, will my patient benefit from giving fluids? Okay? Because there are some people who will benefit from fluids even if they're not hypovolemic. This is called judging fluid responsiveness. How can you judge fluid responsiveness? There are various ways. Clinically, of course, if the person is having thirst, is asking for water, his body is telling you, he may be right. The invasive assessments which we use and trust and swear by, like CVP, Swan-Ganz, echo, are not very reliable, and what you need to do is something called a dynamic assessment. Very simple bedside, old medicine, and I will show you how you do dynamic assessment of this. Biochemical assessment for hypovolemia, very reliable. I told you urinary sodium. In metabolic alkalosis, urinary chloride less than 15 is hypovolemia, and urea creatinine ratio. You will be surprised that doing creatinine without doing urea is useless. Your patient can come to the hospital with a creatinine of 1 and in a few days have a creatinine of 1.6, and the kidneys may be absolutely normal. It might be just you're giving cephalosporin to this person. There are many reasons. If he gets diabetic ketoacidosis, creatinine can go up to 3 or 4 with normal kidney function. There are many reasons. But whenever there is a renal failure, urea and creatinine increase proportionately. So the ratio remains the same. But if your urea increases more and the creatinine not to that extent, which means say urea doubles, but creatinine doubles, urea goes up 4 times, then it's hypovolemia, GI bleed, steroid therapy, or high protein diet, full stop. Steroid therapy you will come to know because you're treating the person. High protein diet you will know, GI bleed you will clinically know. If you exclude this, high urea creatinine ratio is hypovolemia. I see people come with creatinine of 5, 6 and they're referred to a nephrologist who subjects them to dialysis, and you see the urea creatinine ratio was sky high, this patient just needed fluids. Now, I'm going to talk a little bit about CVP because we all use it. How many of you use CVP? All right. There are a lot of people who are shy to raise the hand or think that it's below their dignity. Trust me, it's nice to participate. All right. So, then I'm going to ask you what it means. It's an extremely common measurement. I want to ask you, and this is audience response, what the hell does CVP mean? Does it mean venous return to the heart, Does it mean cardiac output? Does it mean volume status? Or does it mean I don't know or none of the above? Let's start audience response. Everyone vote. Switch on your handset, press that red button. I'm still getting a lot of jarring sound in this. It's very disturbing. No, but there's no point because it's irritating. Huh? Try and see if you can get this better. 3 seconds left. All right. We have majority of you saying, 20 of you saying it's 3. That it represents volume status. Right? I am standing here in front of you. I develop a myocardial and my CVP is 5. I develop a myocardial infarction and my CVP goes to 10. Has the volume in my body changed? My CVP is 10 or 5, whatever. I develop a massive pulmonary embolism. My CVP goes to 22. Has my volume changed? My CVP is 10. I develop septic shock. My CVP drops to 1. Has my volume changed? So, the easiest to exclude is many conditions like pulmonary embolism, sepsis, tamponade, LV-RV dysfunction. You can have CVP changing without change in volume status. So let's strike out 20 answers. Okay? Then, does it represent venous return to the heart? Someone said it does. I want you to now imagine this as a container. Okay? There's a water coming in and water going out. If you take this as the right atrium, okay, water coming in will be returned, volume or cardiac output. The level of the fluid represents CVP. Alright? Now, if I increase the cardiac output and keep the same venous return, what will happen to the CVP? It will fall. If I reduce the cardiac output for the same venous return, CVP will go up. Same venous return, CVPs are changing. So does it represent venous return? No. So let's cut that off. And then I think 1 or 2 of you said it represents cardiac output. Let's go back to this example. Same venous return, cardiac output. If I increase the venous return for the same cardiac output, what will happen to my CVP? It will go up. And if I reduce the venous return for the same outflow, CVP will fall. So for the same cardiac output, CVP is going up and down. Does it represent cardiac output? Now, you all use CVP. It's a physician's conference. Can you, one person tell me what it means? So, what are we measuring? And what are we interpreting it as? That is the fallacy why more and more people are not using a CVP to assess volume status. Now,